Okay, everyone, this is Dr. Tofai joining you for yet again another Hernia Talk Tuesday. Today, we have a very special guest from Europe, and that's why our timing is a little bit different, and we're usually a little bit later in the day. But I'd like you to say hi to Dr. Barbra East. She is a professor of surgery and a highly talented hernia specialist working out of Prague in the Czech Republic, and she's one of the leadership within the European Hernia Society, and a very good friend of mine because I really enjoyed being with her. Welcome, Dr. East. How are you?
Thank you, Sharon. I think your words were too kind. I'm half of what you said, but thank you very much.
I cannot say enough about you, and the reason is you're fairly young among our hernia surgeons. There's a lot of older men with lots of gray hair or no hair in our societies, but your trajectory was very fast, and I think it's because it's a combination of your knowledge and interest and research, and you're highly active in that, but also your personality. And I think in the next hour people will see your personality. It's just so warm and yet commanding at the same time. I don't know, what do you think?
Oh, thank you. I think my career has shot up thanks to the European Hernia Society. That has actually given me a boost start, because in Czech, as a surgeon and as a female surgeon, you don't get much of an opportunity to become a cancer surgeon or upper GI surgeon or anything like this. You have to work really hard if you want to pursue a career in surgery. And because my PhD topic was related to hernias and research, I sort of got involved with the European Hernia Society, and the people around it were so friendly and very supportive, and they encourage anybody who actually wants to work. And that's how I got involved, and that's where it all started.
I think you're right. I think the hernia surgeons internationally, all around the world, are very kind and nice people. They enjoy what they do. It's a relatively low stress specialty compared to like trauma or transplant or cardiac surgery. We do affect people's quality of life very much, and so it's kind of it's very satisfying at the same time. So people are happy and they do like what they're doing. No one goes to hernia surgery that doesn't like what they're doing. You know, no one would choose to do hernia surgery as a specialty if they didn't actually enjoy doing it. Don't you agree?
Absolutely. I have one of my research fellows actually last year in the annual event of the European Hernia Society submitted a poster, which is the 10 reasons why to become a hernia surgeon.
Oh, okay.
And it's actually a really nice poster, and he's only like his second year of surgical residency in his surgical training, and he put these 10 reasons together, which are really sweet. And one of them is that you just don't watch people die, suffer so much. You do something which is a little bit of a cosmetic surgery, but it's not, it sort of makes people more beautiful. You improve people's quality of life. And at the same time, I think we're all a little bit of the underdogs of the surgical field.
Yeah.
Because when you look at average medical graduate who wants to be a surgeon, I think so many of them will just tell you, look, I want to be a cancer surgeon. I want to transplant organs. I want to do this. But not many will tell you, I want to fix hernias. But they don't realize what it is. And one day, you know, they realize they've spent 50 years or 20 years transplanting organs and actually just watching people die slowly. And they actually end up having quite a sad life, I think, compared to us.
What was your thesis on, and how did you get involved in hernias?
My thesis came around by accident, actually, because the university where I was studying and where I ended up teaching as well has a big biophysics department. And the guy who's in charge of that owns a patent for some machine that can electrospin nanofibers out of various polymers. And they were trying to make an artificial cartilage to be used for knees for soccer players, because he's also a very passionate soccer player and the only Czech FIFA judge. So he was trying to build this bioengineered cartilage for the knees of all these soccer players. And one day he was sitting next to my boss at some graduations, and he said, look, I have these fibers, but I only have fibroblasts growing on them. They're like weeds, they grow everywhere. And he said, well, this is the cell we actually want in hernia repair. And I have this girl and she wants to be a surgeon, but I want to give her some topic, which is quite, unimportant. So let's just give her these fibers and see if she can figure out anything to do with surgery. So that's how it started.
And what was the final topic of your thesis?
The topic was the use of biodegradable nanofibers of polycaprolactone, which is one chemical, in operative repair of recurrent incisional hernia. I'm very sorry. We have another person joining us. And
the Dr. East is a brand new
I'm sorry.
This little boy is 6 months old.
That he will be nice. I'm sorry.
Oh, looks like he really enjoys being on the Zoom. That's so cute. 6-month-old little boy. I remember when you were pregnant and you were presenting at the conference. I forget. I think you were like 7 or 8 months. 6 or 7.
Yeah, 6, 7, something like this. Which was actually really wicked because I got given a topic to present on inguinal hernia and pregnancy, and I became pregnant like 2 months later.
Yes.
And I said it to Wolfgang.
Pregnant, I remember. Yeah, I totally remember that. Well, this is good because based on your experience, we have many questions about mesh and mesh properties, if we can delve into that. And we're also going to be talking about pregnancy. There have been those questions. So should we start with some of those already? Yeah. Okay. So the first question is just on the different types of mesh. There's polyester, polypropylene, ePTFE, and PVDF, which are the most popular synthetic meshes that are non-absorbable. Is there a reason why a surgeon would choose one type of mesh over the other, and are there any that we should avoid? What are your thoughts on that?
I can tell you in the Czech Republic, I can only choose polypropylene. I can't choose any other because we only have, or majority of our health system is state, and the other, we don't have polyester on the market, and the other's too expensive for us. But these are, it's like every material has certain properties. So if you look at polyester and polypropylene, they are basically equal or used interchangeably. Although in the animal studies, polyester causes a little bit more of the foreign body reaction and is a little bit more pro-inflammatory compared to polypropylene, but I'm not aware of any human, like any study or any paper published on humans with this, but it's quite commonly mentioned on animals.
I mean, the original stopas and the original hernia repairs were all done with polyester. Well, after steel, you did steel first, that didn't work, that kept breaking. And they used polyester, and it was very soft, it was very fabric-y. Yeah, and polypropylene came about. It was much easier to make and cheaper to make, and the properties were good at the time, and it was monofilament, whereas polyester was braided. So one of the major reasons moving from to polypropylene was like you said, the foreign body reaction was lower, and because it was monofilament, and the infection rate was an issue, because if you got the polyester infected, that was a very difficult thing to handle, whereas with the polypropylene, not as much. PTFE is kind of became popular and is not as popular anymore. What are your thoughts on PTFE?
I don't like it. I've never used it, but I don't like it, especially because of the infection of it. And because the pore size, if you just have something where you can't treat an infection in, then I don't know, I wouldn't use it myself. I wouldn't want to have it in myself.
So PTFE came about, I think in our hospital was where it became most popular because a surgeon, I believe it was Dr. Amid, was looking at a way to put a barrier so you can put mesh inside the abdomen. And he tested a lot of different properties of different products, and PTFE was the one. And that made laparoscopic ventral hernia repair like a big boom in the early 2000s, which was all PTFE based materials. We know that shrinks much more, and it's very much not resistant at all to infection. So if it gets infected, that mesh must come out because it's very microporous. So there are still products that are PTFE based, and they use it around, because it doesn't stick to anything, it's considered to be safe around bowel, like colostomies, and around the esophagus, really important structures you don't want to erode into. So it does have some use, but it's not as popular as it used to be. You know, PVDF is only available, I'm sorry, not only available in the US, in Europe. It's not available in the US. It is available in Europe.
Yeah,
and
actually, I just realized I do use PVDF mesh for the laparoscopic groin hernia repair.
Yes. So what do you think of that? Because from what I understand, the Europeans love PVDF. It's very German.
It is German, yeah.
German-centric, but based on the German experience, and of course the German Hernia Society is, I believe, the oldest of the hernia societies and the one with the most history. So they're very proud of their hernia society.
I think it's the biggest. I'm not sure if it's the oldest.
Oh, biggest, not oldest?
Not sure.
Okay.
I think the French keep saying theirs is the oldest, but
I see.
Know.
Maybe.
I hope nobody's listening.
Yes. So what do you feel is different with PVDF than polypropylene? Why do you use that for the groin?
I use it because the manufacturer who makes this mesh just makes it in a shape and a form, and the properties are just so nice to handle and always fits well. You can use just a polypropylene flat mesh, but I always felt like with this one there's a little bit less work, while with the 3D meshes I'm not a big fan of those because they're like too bulky and I find it quite hard to make them fit right. But this one is relatively soft, but it's also but it's also quite easy to handle, and it fits really nicely.
The company that sells PVDF in Europe tried to come to the US. From what I understand, the FDA process was too onerous, and we have such huge other companies that are leaders in hernia mesh that they felt that from a financial standpoint, they wouldn't be able to compete after all the money they had to pour in for the FDA process and then market it in the US. But it's a braided polypropylene-like product. So it's supposed to be less inflammatory, less shrinkage, and lighter weight than polypropylene. Is that right?
And on IPOM in the intraperitoneal position of the mesh, which didn't actually work that well. But for groin hernia repair, that's my favorite mesh, and I just use it because it's easy to handle. And
what are your thoughts about? Yes.
Thank you.
What are your thoughts about biosynthetic meshes? One question specifically asked about the Gore Cinecore mesh. There's also the Telebio Ovitex mesh. There used to be the Cook mesh called Xenopro that's been taken off the market. And there's also the absorbable synthetic mesh called Phasix made by Bard. So what are your thoughts on biologic mesh and hybrid mesh and biosynthetic mesh?
Well, biologic and biosynthetic, I think, is a little bit different mesh. And I think we start with biologics, and I think it's a really cool idea. And it's basically the same idea as we were using in our research with the nanofibers, because when you electrospin some polymer, you end up with something that looks very similar to extracellular matrix. And the idea is that you convince someone's cells to actually inhabit that area, turn it into a big house for all the fibroblasts, and then eventually eat it and reform it into a new tissue. It's the whole basis of tissue engineering. And I think biological mesh manufacturers had very same idea, and they were thinking that they're going to do also, if you remember the old advertising for all these biological meshes, they always said it's regeneration instead of reparation and things like this.
Yes.
And it would have been great had it worked. But I think, and I can't tell from my own experience, I can only say from what I've heard and read, but because I've never used a biological mesh, and it's just way too expensive for the Czech medical system to cover that cost of a biological mesh. But I can see that the world is sort of sees it as a dead-end street, and it didn't quite deliver the results which we were hoping for. So meshes like the Bio-A came to the market, which cost half price. Under the microscope, it looks very similar, and it, in theory, should have a lot less antigenic properties than something that's been taken from a cadaver or from a cow or a pig. Or so it's I think the idea behind it is fantastic, but why it doesn't work the way it should work, I think it's for the engineers to figure out. But the idea is very good. And with Phasix, I think it's too early to say, because it's not on the market for long enough. And if you look at the evidence behind Phasix and the evidence which allowed it to be brought into the market, there's very little. And it's based, again, on animal studies. And I think only the post-market surveillance is going to tell us if it was a good move or a bad move. You know, ideally it's going to disappear and not harm anybody in the long term, but who knows?
The kind of mid-long term studies have come out, and the long terms, I think the recurrence rate's around 20%. The mesh that you're talking about, the Phasix mesh, is a synthetic product that absorbs much more slowly than most biologic mesh. The theory is that around 18 months is pretty much out of your system. But if you continue the study after 18 months, then you start seeing recurrences. You know, that may be fine. A 20% recurrence rate may be okay in someone who has a lot of other issues that you don't want to add, you know, permanent synthetic in, or if you want to keep operating on someone over and over again.
Yeah, maybe, you know, something temporary. If you have a lot of, I don't know, you have a stoma, you have some fistulas, something that's going to be reversed in the future, but you also have a big hernia, then I think it's a good product to use. But again, I don't think there's much evidence behind it at the moment, so can't really tell.
What are your thoughts on, here's another question, then we'll move on to pregnancy questions, which we have multiple. What are your thoughts on, you know, tissue versus mesh? By the way, just to preface, US practice of hernias are different than European practices. Part of it is we're kind of expensive surgeons. We have tons of different types of mesh products that are sold to us. We have a lot of options for biologics, which are very expensive and typically not covered in a more socialistic healthcare system, which a lot of Europe is. And so when we use biologics or these fancy meshes in the US, it's really good to talk with someone in Europe where you are bound by much more restrictions financially in the healthcare system than we are. And therefore, I suspect you also do more tissue repairs than we do. Is that correct?
Well, when I started for groin hernia in the clinic where I started to work, for groin hernia, we hardly ever used mesh. We did mainly tissue repair, and we did some of these that you only read about in some really historical books now. So we didn't even do shoulders. We just did some Bassinis and McWays and some like really old-fashioned repairs. But you see, when you do a high volume of these, first of all, you learn the anatomy, I think, a little bit better than if you never have to handle these tissues. And because you do it repeatedly, you somehow learn what to sew to what, and then the recurrence rate drops, because it's not like when you have a whole lot of surgeons who used to use mesh and then you force them to do a study when they do a repair which they are used to doing with mesh versus something which they're not really trained to do. So then the recurrence rate suddenly on the non-mesh group is much higher. We didn't do any systematic follow-up at that clinic, but I remember one guy, he was a rubbish man. He was do you call them rubbish man? The one who collects rubbish bins? And, yeah. And my boss back then, he made me do Marcy repair, which is basically you just put 2 stitches around the internal ring. And I said to him, I said, no, you know, he lifts these very heavy rubbish bins. He needs a mesh. We have to use a mesh. And he said, well, do what you want, you know. And then I thought, well, he's 40 years older than me. He knows better. So I did what he said to me. And then the same guy came with perforated stomach ulcer about 6 years later. And he came when I was on call again. And I said to him, so how's your groin? He was like dying from stomach pain. But he said, oh, my groin's good. Groin's good. So it's, I don't think mesh is always needed. And I think you can do on certain patients in the groin hernias, you can do tissue repair, which lasts for the life. And it could be a good repair. For some, you need mesh. The same is for umbilical hernias. I think for lots of little umbilical hernias, you can get away with a couple stitches in the umbilicus, and that's it. I don't think.
What is your practice for inguinal hernias? How often do you use mesh?
Well, the clinic where I work now, majority are done via Liechtenstein, so like everybody receives mesh. And when I started to work there and I started to do these tissue repairs, they were looking at me like, I don't know what I'm doing. They're just like, what you doing? You know, you don't know how to use the mesh, do you? And they do, but I don't think everybody needs it just because it's the current gold standard. So they didn't do much laparoscopic repair, which they're starting to do now. But again, the primary focus of that clinic is lung transplant program. And they do hernias just as a tiny little sub part of what they do. So it's something very unimportant for them.
And what is your practice for umbilical hernias? How often do you use mesh for that?
Myself, I use mesh if the hernia is big, or if it's a patient who is quite large, has a diastasis, then I would do it. But I've never used any of these like patches, like these preformed intraperitoneal patches. Again, they're too expensive for us, so I have no experience with them myself. But if we use mesh, we just use flat mesh and try to keep it out of the abdomen. But the little ones, I just put a couple stitches in.
I agree with you. I think in the United States, we tend to overuse mesh. There are plenty of patients that would do just fine without mesh. It may imply a longer recovery time, actually. We know that. But that may be okay for some patients. In countries that don't have access to mesh or have only the very kind of basic mesh types, I feel like they don't have as good of outcomes. They have some disasters they have to deal with that are very hard to deal with once they have recurrences. So that's one drawback. But the other thing is they also don't have a lot of the chronic pain issues that we have with in the United States with mesh related overuse. I think there's overuse.
Yeah, and I think it's not just overuse or underuse. I think it's the correct use. And I think you should, when you use a mesh, and whoever you are, you might not be a hernia dedicated surgeon. You might be any surgeon, because we both know that any surgeons operate on hernias. Many surgeons who don't really have big hernia interest operate on hernias. And unfortunately, there are so many cases when the surgeons don't even know what they're using. They just passed a product by the scrub nurse and they just use it without knowing what that material is. Yeah. Quite often you see they use a mesh that's too small, in my opinion, especially for incisional hernias. They try to patch up a tiny bit of that scar. You know, you have a long scar and you have incisional hernia and a little bit of it, and then they put a little patch, and then 6 months later the patient has another hernia right underneath it, so they put another patch, and then eventually there is a hernia in between these two, and it ends up with some perforated bowel and infected meshes, and then it ends up in a disaster, partially because they just didn't use enough mesh and they didn't use technique appropriate to fix that hernia. So I think it's also correct use, not just the type.
You're a member of the European Hernia Society, and the EHS has done the best job of all the different societies in trying to work with evidence base and publish guidelines for both inguinal and ventral hernias as to where the evidence is, where should mesh be placed, where shouldn't mesh be placed, what techniques, what decision-making in surgery, and so on. And I feel that Europeans have done a really good job of that. And it's so important because obviously it's important if people read it, but it's still important that that information is out there. And it's a lot of work because you go through every single possible literature that's out there to help support these really intense, super detailed guidelines. But my point is, similar to building a house or repairing a leak in the house, you have good contractors and bad contractors, good electricians and good plumbers and bad electricians. So if you get the good one, you know, they'll fix it and they'll plug your leak the first time. But if you get one that just kind of wings it and just does like a minimal job, you're going to leak again. You're going to have to call another plumber. So yeah. Surgeons are kind of like that. We're all trained similar, but at the same time, slightly different manner. And every country is different. Every institution has its own kind of system of training. And then if all you do is hernias, you're probably more likely to do it correctly the first time. What happens is those of us, and I'm sure you're in that same ballpark, which is when you're the specialist, you get all the ones that failed the first time. You don't get the
first 5 times.
No, first 5 times, right? You know, it would be ideal, in an ideal world, everyone would repair hernias perfectly the first time. I'm not implying that we don't have complications. I have plenty of my own complications. Anyone who operates will have a bad outcome or a recurrence or something. But we kind of know how to handle those complications. We have some more questions for you about surgical technique. So what kind of technique do you use for your open inguinal hernia repairs?
It depends on the patient. Every patient's different and every patient has a different wish as well. I think it's important to speak to them and agree what do they want and what do they expect from it. So like a couple of days ago, I operated on the director of the primary school where my son goes. He wanted laparoscopic repair, so he had laparoscopic repair, and I think he was very suitable for it. And across the road here, I have a neighbor who had a massive scrotal hernia, which he had for 25 years. And his scrotum was all the way to his knee, so he had open Liechtenstein repair, because I felt that that was the most appropriate for him. He agreed to have a mesh. He wanted one. And it's kind of nice because I look at his house from my window, and I saw him the other day transporting probably a ton of bricks from floating a ton of bricks. So I popped in a couple of days later and I said, "Are you still okay?" He said, "Yeah, it's okay." So I think it all depends on the patient.
You live on the outskirts of Prague, is that right?
Yeah.
How far are you from the center of town?
About 20 minutes by car, half an hour by public transport. Prague is not that big, so
That's pretty far away then.
yeah, I think the official border of Prague is about 1 kilometer away from our house. The airport is just here, so we always joke that we're in the closest place to wherever we need to go, like America or New Zealand or anywhere. But yeah, Prague is not very big. It's quite small.
Very green. You must be so green where you live.
Yeah, it is. It is. Actually, Prague is the greenest capital.
Interesting. I did not know that. I was in Prague for the EHS back in 2000, I want to say 2006 or 7, where the EHS was in Prague.
Yeah, it was like 2003 maybe, or even earlier than that.
It was the year that you became an EU.
Yeah, I think it's 2003.
Oh, Dr. Gok is on. He says it was 2004. Thank you.
2004, Hakan. Thank you.
Okay, one question technically about Liechtenstein. Your pubic tubercle stitch, where do you put that? Is that into the periosteum or into the rectus fascia, or what's your technique?
Well, I try to avoid the periosteum because I was told it causes chronic pain. So I try to avoid it, but it's not always possible, especially in certain patients. And again, if you're I think we're very lucky in Czech with the mentality of the patient as well, because it's not like US. You can't, I think you can, but almost nobody sues any doctors or does any damage claims or anything like this. And goes from the history, all the care is free to everybody, and people just come with the problem, and they don't expect like so much of an individual treatment, and there's a system works differently. So if you're a little bit kinder than the average person, and you speak to them and you explain it to them and you say, look, you've had this operation 5 times before, we've sort of ran out of options, so we're just gonna do whatever we can, and you may have some pain afterwards. They're usually very good with accepting this and living with it. I don't know, how's it with you? Maybe your patients would accept it as well had they been explained.
For sure, in the United States, there's much more stress as a surgeon. As a doctor, I would say in general, as a surgeon, a little bit more, because you're operating on people and it can cause more damage than non-surgical. Malpractice lawsuits are huge. We pay a lot of money to have malpractice insurance. A big chunk of what we make is for that. And pretty much every surgeon I think close to 100% of surgeons, it's a really high number, will get sued at least once. So it's one of those things that you live with, but it's stressful. It's stressful when you get sued because it's a long process. It becomes very personal sometimes, and you know, most surgeons are not out there to hurt anyone. The majority of us do what we do because we like to help people, and sometimes it's not even your fault, but a patient may be angry. It's a very complicated situation, and I would much rather operate in a world where lawsuits was not part of my daily world.
Yeah, come here.
Have you ever used the Prolene hernia system?
No.
No,
we used to use them when they, probably 6-7 years ago. We had about a year when they were very fashionable here, and we used them, and then I've taken quite a few out, and then we just stopped using them.
Why?
I think some I took out for recurrence, and some just because people kept and they said they have a feeling that they have a bulk of something in their groin, and they did have a bulk of something in their groin. They were absolutely correct. But again, I think it was because they weren't used properly. They were designed for certain type of hernia and certain type of patient. And if you suddenly start using something like this for all your patients, you're going to have a significant part of those who are not suitable for it. So I don't think it was necessarily just the problem of that mesh, but also of the abuse of it.
It was a good design idea. I think most surgeons were not able to use it perfectly because it's got 2 layers. So most hernia repairs one layer, so you have to make sure that one layer is perfectly placed. And this one you have 2 layers, so now you have to have 2 layers perfectly placed, which, you know, doubles your chances of it not being perfectly placed. And it is more.
And I've seen actually a lot of surgeons trying to use it for indirect hernias, and sort of using that cone part to wrap around the cord, the spermatic cord, because they thought that's what it's for, and things like this. And
like a sleeve?
Yes.
Yeah, no, that's not. Yeah, okay. I know that it's already done its peak. It's kind of on the other side. Most hernia specialists do not use it anymore. There's a handful that still use it, but they're probably doing very well with it. Do you do peristomal hernia repairs?
Very rarely. Most colorectal surgeons do them themselves in Czech, and I did it again on the clinic where I worked before. I have calculated our peristomal hernia patients, and I think it came to something silly like that 25% of them died within 1 year of the operation, and the 75% had a recurrence. So, you know, the results were really, really bad. And at the clinic where I work now, I actually have one peristomal hernia scheduled for later this year, and I think it's the only one I'm going to do this year.
And what technique do you use for that? Is it the sugar baker?
No, no. Most of my colleagues would use just an onlay mesh, and they would relocate the stoma. That's still pretty much the standard here, which I don't fancy. So for this one, I would like to try this technique that Agneta Montgomery is promoting. It's LOPA, where she does it from the orifice of the stoma, and she does sort of retromuscular repair with a mesh, but from the stoma side.
Yeah, up until I think almost 10 years ago, just a little bit, maybe less than that, 7 years ago, if you're a colorectal surgeon, you had to take the colorectal board exam. When they asked you about peristomal hernia, the correct answer was what you said: resite the stoma and then repair the former peristomal hernia as an incisional hernia. That is no longer the case. In the hernia world, we recommend the sugar baker repair. There's also the keyhole repair. There's the Pauli repair, which we discussed last week with Dr. Pauli. polyperistomal hernia repair. But the resiting is no longer considered the best anymore. It's an option.
Yep.
But I feel that the hernia world encouraged the colorectal surgery world to change their practices, because we both repair those hernias. And now the answer to the colorectal surgery boards is it's exactly that. Either you just primarily repair the hernia, either as a sugar baker or a keyhole technique. That's the most common.
The problem I have with sugar baker is, again, it leaves a mesh in the peritoneal cavity, and I don't know, maybe it's just me, but I have a problem with it. So if I can, I would try to avoid it.
One more question about mesh, and then I'm going to move on to the pregnancy. So I really want to get your opinion on all of that. What's your opinion on the best method to secure mesh, especially in the groin? Do you use glue, stitching, tacks?
Laparoscopic repair or open?
Laparoscopic.
In most patients, I don't fix mesh at all. And if I have to, I use glue. And the glue I use, I don't know if I'm allowed to say any brand name, but we use like really cheap histoacryl glue, which only costs equivalent of about $4.
Mm-hmm.
You get a very fancy applicator, which costs another $100, but Jan Kukleta has taught us a method how to use just the pipe from an infusion set and apply it through that. So then for $4 or $5, you have a glue with an applicator that you can use perfectly safe.
I think yours is cyanoacrylate. I don't know that we have. I don't think our FDA approves cyanoacrylate for inside the body. So ours is much more expensive glue. It's like hundreds of dollars just for the glue.
Yeah, not for us.
Okay, so let's move on to some pregnancy questions. Okay, easy one. Should I have a hernia repaired before or after pregnancy? Inguinal or
what hernia?
Tell me your answer for or ventral.
Oh, ventral, if you mean like primary ventral, like umbilical hernia, then even if you read the guidelines, and we have written the patient-friendly version of the guidelines that anybody can see on the European Hernia Society website, then we recommend as a group that you should wait after your pregnancy, after your last pregnancy, ideally, if you can. With groin hernias, there is not that many young women with inguinal hernias that I know of. So I think if you have one, I would just get it repaired. If you have a femoral hernia, definitely get it repaired. But there is no need to wait, because when you become pregnant, nothing happens to your groin. It's not like the belly button that sort of ends up being somewhere else, but not your groin.
The groin hernias get repaired whenever you want. It doesn't affect pregnancy. And then umbilical hernias,
I would wait.
Wait until you're done with all pregnancies. Otherwise, the recurrence rate and chronic pain rate is higher. Correct?
Yeah.
Okay. So on that note, is it safe to get pregnant if you already have an umbilical hernia?
I have an umbilical hernia and I was pregnant twice. And I believe it's perfectly safe.
100%. You have a 0% problem rate. All right. This was a funny one. Does an umbilical hernia affect your period?
You mean the strength of it, or I'm not sure I understand the question. I don't think so.
As they come. Yeah, I think the answer is pretty definitive. No, it does not affect your period. But I must say, umbilical hernias can give you bloating, and the pain from the hernia may be worse during your period, right?
Okay.
The hormonal changes can make it worse, but that's about it. This is someone that reached out to me on Instagram. I told this patient to join us today. So incisional hernia was repaired and recurred, and this patient is morbidly obese with a large pannus. They want to come to see you. They live in your part of the world. So what would you recommend to them?
Well, if they came to see me, I would sign them up for our program. We have developed with our sports medicine department. We have developed a program about 5 years ago, which is completely free for all the patients, as most healthcare in Czech. And they get a physio, and they get 3 times a week access to a gym where they have a physio present there, and they have a dietitian, and for 3 months they're trying to lose weight, or at least like lose a little bit of weight and improve their muscle strength and work on their diaphragm motions and on lots of other things. And after 3 months, most of them decide to continue another 3 months. And in these 6 months time, most people are usually able to lose about 5 to 10% of their body weight if they're morbidly obese. And that's enough for us to get a little bit more space in the abdomen, to operate on them this little bit safer and with slightly higher chance of succeeding. And then taking the pannus away, I think it's a standard part of the incisional hernia repair nowadays. At least for me, it should be.
Yeah, we were with Dr. Paula last week, and that week for him was just filled with morbidly obese patients that have had weight loss of some sort and a recurrent incisional hernia that required a combination procedure. In fact, within an hour before his talk with me at HerniaTalk, he texted me and said, "I'm starting a case. I hope I won't be late." So he did his portion, and then while he was talking with us, then the plastic surgeons were doing their portion of the operation, which is the pannus and so on. So yeah, that combination procedure seems to work very well on patients, even though there's a higher risk of wound complications in that population. I'd like to you to share with me a little bit your experience. Many of you who follow you on Twitter and Facebook know that you're very interested to learn more about what it is that patients want us to work on in hernias, and kind of gear the surgical efforts towards that. I'm sorry to hear that even though you had very generous and bona fide interest to get to know more from the patients, you got a lot of backlash for asking that question. You had a survey that you sent out for anyone who's had a hernia repair to answer. Give me a little bit of background, what the purpose of your survey was and how it's gone so far. And what I can do is, in addition to the patient-friendly European Hernia Society guidelines, I will also post your survey if it's still open for people to.
Yeah, it is.
Tell me more.
Actually, the survey started because I was writing a guideline document for our guideline group, how to write guidelines properly. And the methodology we're using is called GRADE, and it dictates that if you are writing a guideline for surgeons which operate on patients, you have to ask the patients, what do they expect? They're the most important stakeholders. And I think it's something that surgeons still, not all surgeons are absolutely aware of this, that it's the patient's body and it's their health. And I was looking through the literature, and there isn't much published on what actually patients would like, because we as surgeons, we measure recurrence. It's something we can measure. We can measure pain, but again, think how many surgeons would deny that the patient has a chronic pain, or because they don't want to see it. And it's something which is not so easy objectively proven as the recurrence. So recurrence has become something we all focus at the most, but I wanted to know, is it the recurrence that the patients actually fear, and how important is it that they can choose between mesh and non-mesh technique, and are they happy to accept maybe slightly higher rate of recurrence but avoid the mesh? is chronic pain something that they really don't want, or are they, are they again happy to live with some pain if they don't have a recurrence, or is the cosmesis the most important? And so I put this survey with very kind help of two of our patients, which come to our meetings, and they have helped me a lot, and they put some more people in contact. And actually, a really lovely lady joined us through Twitter who I've never seen, and she has done an enormous job on the survey and helped us enormously. And we put it out, and the results been it's been a big eye-opener for me. And I guess I came from a little bit naive environment, and it was like taking a cold shower for me. I realized that there is very little trust between patients and surgeons, and they see us as something evil. And I didn't mean anything evil, and I didn't mean to hurt anybody with that survey. All I wanted to do was give patients voice. And it's very hard to publish a paper in a good journal to make other surgeons read it. If you publish it in a tiny little journal, nobody's going to read it, and nobody will give a think about what it says, and nobody will take it seriously. So I thought, if I want to publish it, so the surgeons, and it's not the hernia surgeons I was targeting, but all the general surgeons who operate in hernias, to make them read it, I knew I need to reach a certain number of people to respond to that study. So the reviewers of the magazines where I would send it will not say back to me, oh, you don't have enough numbers, so it's not important enough, and we're not going to publish it. So I was trying to get as many patients as I could, and I posted the survey on all these mesh groups and patient support groups. And I actually have written a little editorial which is called Entering the Lion's Den. And it got rejected from one magazine so far. So I don't think that, I think maybe I'll just put it on IHC one day and let my friends read it. But it's very hard to sort of defend someone's rights if they see you as one of something they're fighting against.
Yeah, if they don't see you as their advocate, that's a problem that I've experienced as well. In this specialty, United States, is there's a lot of mistrust. It may be why there's also so much lawsuits, or maybe the lawsuits, lawyers are promoting more mistrust. I'm not sure, but it is stressful, and we've discussed this in different HerniaTalk live sessions. I know that I posted your survey on HerniaTalk. I hope some of the members of HerniaTalk who are very involved in online on the discussion forum, the free discussion forum, probably filled it out for you.
Thank you.
I will post it again for you. And on all the other platforms, and hopefully we'll get a little bit more feedback and not so much hate mail for trying to do good. You're getting a lot of thank yous in the question and answers for graciously and generously sharing your vast experience. Question from, oh, and by the way, we have people from the UK, Italy, Turkey. You've got a nice international group joining us live.
Buonasera.
So one question is about these patient groups. Did they direct their mistrust or anger? Do they make derogatory comments against you personally? And what they actually are curious about, what examples in general you've experienced?
Well, some reactions varied, and there were some people who were extremely helpful and grateful and very, very nice in these groups. But there was always somebody, who was one or two people who were like very angry, and to begin with, they did actually have some very derogatory comments to me and sending me back to medical school and things like this. And And a lot of people, there's lots and lots of patients who believe that the mesh hurt them, and they don't see that there's somebody who put the mesh in them. The mesh didn't just unpack itself. It didn't climb into their bodies while they were asleep. They believe that some mesh is made of some toxic materials, and they might be right. And in some certain extent, they might be right. But I sometimes felt like that there are certain members of these groups that are almost like blindly believing something, and then anybody who has a different opinion is like Satan to them. And that's what I've become in some of these groups. In some, we actually got engaged in very good conversation, and I was approached by some people asking for help. I tried to do my best. Again, I'm sitting in Prague, Czech Republic, so it's very hard for me to help somebody who's in Australia, but I tried to do my best. But I think there needs to be more dialogue between patients and surgeons, and that's why we do the patient info page on the EHS website, and we're hoping to again provide a little bit more of valid information to the patient population.
I will provide a link to that for our viewers so that they can, it's always there online. I think it's time for us to let you go back to your family, your little baby, and it's almost 10 o'clock at night at your time. So for bedtime maybe. You're working tomorrow, I assume? What's your day looking like tomorrow?
You don't want to know. I'm taking my grandmother to the dentist. So
okay.
She lost her front tooth. She tripped over and lost her front tooth. So it's going to be our 4th trip to the dentist, and she's getting a new one. But I don't work. No, I don't actually have any work scheduled until October, really, when I start working again. So I only go to the hospital when I want to now.
Yes.
Which is quite nice.
Okay, well, it was so lovely for you to share all that, and a lot of your friends are on here. Thanking you very much. I'm going to leave everyone here as a big thank you. All of you know that this broadcast is being simulcast on Facebook Live. I will also edit it and put it on YouTube so that you can watch it all on YouTube. I will post the link to that. It's basically on my YouTube channel. And on Twitter and Instagram, I will also link those. I also owe you 3 things. I will put up the link to the EHS patient guidelines, to the European Hernia Society patient information page, and also to Dr. East's survey. Is that survey only for people that have had hernia repairs?
No, it's also for those who have hernias and are thinking about repair, or just don't want repair for whatever reason. And it has a plenty of space to give your personal views and opinions.
Okay, so we will do that. And thank you so much. Hope to see you
Sharon.
soon. I miss you so much. You're such a wonderful person, and I'm so glad to know you. Thank you very much, and thanks for spending time with us today.
Thank you, Sharon.
Thank you. Bye, everyone.